Drug companies around the world are racing to find a coronavirus vaccine. But what happens then? Distributing doses to billions of people worldwide will be an unprecedented logistical challenge. Limited supply and enormous demand. It's a recipe for cutthroat competition. As wealthier countries shell out hundreds of millions of dollars to secure coveted first access to vaccines, meanwhile the most vulnerable are at risk of being shut out.
There's never going to be enough vaccine to go round globally. Access will be an issue. Some of these first vaccines are likely to be extremely expensive, certainly well beyond the purchasing power of many lower middle income countries.
Developing the vaccine is only half the battle. Getting it to people could prove an equal challenge. In the race to find a coronavirus vaccine, the stakes could barely be higher. Not only are millions of lives potentially on the line, but whoever wins that race will take their place in the history books as the nation or organisation that rescued the world from a deadly pandemic.
Just days ago, Russian Defense Minister Sergei Shoigu was one of the first people to receive Russia's new coronavirus vaccine. The jab was nicknamed Sputnik 5, recalling the pioneering Soviet satellite, and it was approved last month. International experts were skeptical, saying high-profile guinea pigs are no substitute for wider-scale testing. But the race is on, and some countries are confident an effective vaccine will be available by the end of the year. Worldwide, there are well over 300 potential vaccine candidates. 33 of these are being tested in clinical studies. 280,000 people in 34 countries are taking part. There are very different ideas about how any approved vaccines will be distributed. The US, for example, says it's willing to share a possible coronavirus vaccine with the rest of the world, but only if it is adequately supplied itself. AstraZeneca agreed with the European Union to sell at least 300 million doses for member states. But the company had to suspend a study after one test subject fell ill for reasons that are still unclear. The Chinese say their research is also generating a lot of interest. Sinovac Biotech and Sinopharm even showed off their vaccine candidates at a Beijing trade fair. We've received a lot of orders and proposals to work together from abroad, including using our vaccine and clinical cooperation. The World Health Organization is warning against what it calls vaccine nationalism.
The first priority must be to vaccinate some people in all countries rather than all people in some countries. This is not just a moral imperative and a public health imperative. It's also an economic imperative.
But who will be the first to be vaccinated? This question is also being hotly debated around the world. Should those at greatest risk be given priority? The WHO suggests countries receive doses proportional to their populations. But a group of international health experts says that approach is flawed because the pandemic hasn't hit all countries equally severely. They've proposed a three-phase plan called the Fair Priority Model, saying the goal should be reducing premature deaths as well as the long-term health impact of a coronavirus infection. The researchers say 3 basic values must be considered when deciding who gets the jab first: benefiting people and limiting harm, prioritizing the disadvantaged, and giving equal moral concern for all individuals.
And we can now speak to one of the health experts behind that fair priority model for distributing the coronavirus vaccine. Dr. Ezekiel Emanuel joins us from the University of Pennsylvania's Perelman School of Medicine. Thanks a lot for taking the time to talk us through this. So how is your model fairer than, say, like the WHO says, by distributing it by population size or doing it by population age?
Well, if you do it by population size, that I like to say is analogous to the physician in the emergency room looking out at everyone who's waiting to be seen and says, all right, I'm giving 5 minutes to each of you, ignoring how sick the patients are. treating the person with a sore throat or a fever the same as a person who has a heart attack. That seems absurd. You would focus your attention on the sickest people where your attention can do the most potential good. And that's the principle that we say, limiting harm, prioritizing disadvantaged people. Those are important values. And if you think about that, that means focusing your vaccine where you're going to do the most benefit in terms of reducing the number of premature deaths. Then, once that's under control, mitigating the economic and social harms, reducing unemployment, reducing poverty, and trying to get children back to school. And that makes much more ethical and prudent sense, frankly, than saying, all right, 3% of the population or 20% of the population of every country gets it.
Yeah, to go back to your emergency room analogy there, that particular situation relies on the expertise of the doctor to triage and work out who is the priority. Who does that fall to in reality? You know, when we are talking about distributing the coronavirus vaccine, who makes those really subjective judgments?
It's not a subjective judgment. It looks to data, which countries are suffering, where will the vaccine do the most good in terms of interrupting. So I disagree with you that it's subjective. Second of all, we do, you know, as you point out or suggest, we lack a world government that can order this around. We do have international institutions, the World Health Organization, along with Gavi that distributes vaccines, has set up this COVAX facility to distribute vaccine to low and middle income countries and to countries that purchase it. We have vaccine manufacturers themselves that have said they want an equitable distribution and a broad distribution. And then we have governments that have to take the moral leadership in this case and the prudent leadership. Let's face it, the world's not going to get back to normalcy unless most of the world gets vaccinated. And so there's an interest in making sure the vaccine is fairly distributed. What we haven't had until our paper is really a framework to think about what is fair distribution. And we're hoping having this framework will galvanize a consensus that that's how we have to distribute the vaccine. Let me just go back.
Well, if I could just interrupt you, because we're talking about compiling data that could be complicated to compile. It could take time. In comparison, certainly, with just judging it by population size. Is there a danger that analysis like that could delay the distribution of a vaccine?
We already have various groups making the kinds of estimates that we have suggested. Our suggestion would fine-tune what they're doing. They are estimates. They're not going to be perfect. Just like population is really an estimate, it's not perfect. And we think it's morally much superior to simply distributing on the basis of population. Here, let me give you another example. Taiwan has had fewer than 500 COVID cases and 7 deaths. Giving it a vaccine is not going to mitigate much harm compared to, say, Brazil or Peru or other countries that are right in the middle of a serious explosion of COVID. It doesn't make sense to give 3% of the population of Taiwan and give Brazil less doses of a vaccine because you've given it to Taiwan. That's just not a reasonable thing, given the fact that when Brazilians die, it's really tragic. And Taiwan is a country that has done extremely well. And that seems to be morally important.
Just quickly, because we are running out of time, who do you want to hear this advice that you're giving?
Well, I think international organizations like the WHO that selected the population model, the COVAX facility, but I think also world leaders who can influence this and want to do the right thing, but just haven't known what the right thing is. I will point out that Justin Trudeau of Canada led 6 other prime ministers in writing an op-ed in the Washington Post in the United States saying, we want a fair and equitable distribution. Well, here, Prime Minister Trudeau and the other prime ministers, here's what that would mean. Now take it and try to get the rest of the world leaders to abide by it.
Dr. Ezekiel Emanuel from the University of Pennsylvania, thank you very much for joining us.
Thank you.
And now it's time for your questions to our science correspondent, Derek Williams.
My test is positive, but I'm asymptomatic. Should I receive any treatment at home?
Many people who test positive for COVID-19 remain apparently healthy. Our best guess at the moment is that about 30 to 40% of those who contract it won't report any symptoms. But if you tested positive, you still need to go into isolation, just as you would if you had the full-blown disease, because you can carry just as much of the virus as someone with symptoms, and you're likely to be infectious to others even if you feel fine. I couldn't find any specific treatment recommendations for asymptomatic patients, although I'm sure that the standard stuff like staying hydrated and getting sufficient amounts of exercise, even if you're indoors, that they apply. And it goes without saying that you should monitor how you feel closely, as many supposedly asymptomatic people actually turn out to be pre-symptomatic, and they will show signs of COVID-19 sooner or later.
Now let's finish the week by having a look at how the world is doing in terms of coronavirus cases. New cases have doubled in 16 countries and increased in another 77. They've also stayed the same in 11 nations. However, 72 countries have seen new positive cases of COVID-19 go down, albeit by less than half. Meanwhile, 24 have seen cases go down by half or better, and 9 have reported no new cases this week at all. Here's how that bar stacks up against the weekly statistics since the start of the year. There's still a long way to go, but when the right-hand side of that graphic is all blue again, the battle against coronavirus will have been won.